Dear committee, dear colleagues, I would like to present my PhD topic, the novel treatment approaches in penile cancer. My name is Judit Vargha. I'm a urology and andrology specialist. I work at Semmelweis University in the Department of Urology. My mission is to search for a more effective treatment to penile cancer patients and thus improve their life expectancy. We have three topics related to penile cancer. The first one is a systematic review. The second one is an international survey, and the third is a registry analysis. Let me start with the first one, the efficacy of immune checkpoint inhibitors in advanced penile cancer. As a background, I would like to highlight that penile cancer is a real aggressive malignancy. Its incidence is generally low, but it's notably higher in underdeveloped countries. Unfortunately, most patients seek medical advice late when the tumor is already in advanced stage. And for these patients, the gold standard therapy after surgery is chemotherapy. But even despite chemotherapy, the 5-year survival is only 16%, so it's not a very effective treatment. Most of penile cancer are squamous cell carcinoma, which kind of carcinoma have been effectively and safely treated with immune checkpoint inhibitors in dermatology for several years. Based on this, we aim to investigate the effectiveness of immunotherapy in penile cancer patients. Our clinical question was, is immunotherapy more effective and safer than chemotherapy in penile cancer patients? Our population is patients with penile cancer for whom we compared immune checkpoint inhibitor therapy with chemotherapy in terms of efficacy and safety. And our hypothesis is immunotherapy is more effective and safer compared to chemotherapy. We found more than 4,000 articles in 3 main databases, and in the end of the article selection, we have 58 eligible articles. Our first result is overall survival probability in immune checkpoint inhibitor therapy, and we can see a big difference between the studies. The upper two study has better survival rates, and that's why, because in these two studies, the patients got the immune checkpoint inhibitor therapy as a first-line treatment, so we can't pull together the 5 studies. So the overall survival rates, we have 6, 12, and 18 months survival rates with the pooled Kaplan-Meier plot. Or second outcome was progression-free survival in immune checkpoint inhibitor. The same difference can be seen with the first-line and further-line settings. And sadly, after 9 months, there were no enough patients who didn't progress in the therapy. So our last time point is 9 months progression-free survival rate. And before we compare chemotherapy and immune checkpoint therapy, I have to tell we didn't find any article which compare chemotherapy with immune checkpoint inhibitor therapy within the same article. So we decide to collect the data separately, and in the end, we indirectly compare them. Statistically, it's can't comparable, but we see nice results if we put side by side the results, especially in first-line immune checkpoint inhibitor therapy. This is the summarizing of our results. In overall survival, in chemotherapy and further line immune checkpoint therapy is nearly the same, but it's much better in first-line immune checkpoint inhibitor therapy. This is the same in, according to progression-free survival, and with subgroup analysis, we found in immune checkpoint inhibitor therapy that HPV positivity and PDR positivity has better progression-free survival rates. The limitations of our study, there were no randomized control trial done yet, so we use single-arm retrospective studies, case serials, and case reports. We have limited number of patients with very different types of tumor stage and previous therapy protocols. But this is the first meta-analysis, not only in immune checkpoint inhibitor therapy, but chemotherapy too. Individual patients that are in our analysis, and this is the largest patients population to date to evaluate the efficacy and safety of immune checkpoint inhibitor therapy. Based on this, we can conclude that immunotherapy or advanced or metastatic penile squamous cell carcinoma is an effective and safe treatment. We recommend its use as a first-line therapy, especially combination with chemotherapy in selected cases. And we need more studies with direct comparison between immune checkpoint inhibitor and chemotherapy. And we need to search prognostic factors and markers to decide which patients group benefit from the therapy. We submitted our article and we are waiting the journal answer. Our second topic is investigating the effectiveness and safety of penile cancer immunotherapy versus chemotherapy. The PICNIC study, this is an international survey. With our first project, we conclude we need more study which compare immune checkpoint inhibitor therapy and chemotherapy. So we decide to perform one survey. And as I mentioned, penile cancer, the most case histological squamous cell carcinoma. This is the same type of carcinoma, which is the second most common type of skin cancer. And in dermatology, they use the cemiplimab as an immune checkpoint inhibitor therapy for several years with very good results. And based on this result, more and more penile cancer patients have chance to get this therapy. So we aim to collect these patients' data who got the therapy as a first-line treatment. Our question was, is immune checkpoint inhibitor therapy effective and safe in penile cancer patients as a first-line treatment? Our PICO framework is identical as our previous one, and the clinical implication of our study would be to introducing immunotherapy as a first-line treatment for penile cancer patients to improve their quality of life and prolong their survival. So this is a retrospective data collection. We have two data collection sheets, one for first-line chemotherapy and one for first-line immune checkpoint inhibitor therapy. And after the data collection, we will do a propensity matching analysis. We are in the data collection phase now, and in these maps, you can see our co-investigators. Our third project is to investigate the reasons for prolonged denial in patients with penile cancer. This is a registry. Penile cancer is a real disease, and the patients seek medical advice late when the tumor is in a metastatic or advanced stage. And there's a few articles in the literature who highlight that these patients typically came from low social background and lower level of education. And we aim to identify in Hungary the high-risk patients population to decide which patients group need more aggressive treatment for the cancer. Now we are in the data cleaning phase with our project. Summarizing our topics, the first one we submitted, the second and third we planning to submit in the end of this year and in the next spring. And let me introduce some more scientific activities which I take part in the last 2 years. I teaching fifth years medical students in our department. With my TDK student Benedek Gál, we achieve good results with our second topic. I presented several conferences and I take part one article writing, 2 chapters of urology notes for medical students, and 1 international andrology textbooks chapter. And I would like to thank you for your kind attention with a quote from Terry Pratchett: "It doesn't stop being magic just because you know how it works." Thank you.
I would like to ask you if are there any reconstruction surgeries after these penile cancer surgeries, and do you do it in the clinic or not?
Yes, thank you. There's very few reconstruction surgeries. The only reconstruction we can do if you need to do a glans resection to remove all the glands of the penis, we can replace it with muscle or buccal graft. But if we have to remove all the penile or half of, we don't have the chance to reconstruct. Thanks.
This is so nice to see the sequence of different type of trials, so meta-analysis, then survey and finally register. So it's a nice track. So, but at your first trial, you did observe a huge difference between the results of some groups of articles, and this is there any methodologic way to explore this? Although it was just 5 articles and to read details, the methodics and patient population and blah blah blah. Probably, were you able to find something different between these 2 and the other 3, which were very different results?
Yes, that's 2 article, which is better survival rates. The most important, the settings of the therapy, they give the immune checkpoint inhibitor as a first-line treatment, whereas the remain 3, they give the immune checkpoint inhibitor as a salvage therapy. So these patients fall a previous 1, 2, or 3 therapies. So this is the main difference.
Were you able to perform a subgroup analysis on this way or not?
No.
Because of the numbers or
yes, because of the numbers, and in the articles there were no different groups, so we just know how many patients get the therapy, which kind, and which settings. We try to ask the individual patients data from all the 5 studies, but nobody answered, because if you know every patient's detailed data, we can do a more precise analysis.
But did you discuss in your paper? So in the discussion session?
Yes, of course.
Did you spend some body of text to discuss this theory that probably in the future it would be nice to conduct studies in which, as a first-line treatment, this special. Okay, great.
Okay, I know it's not easy. I mean, to answer for the question, what I will have.
Okay.
So it's a poor disease. We can see the 16% of the 5-year-old survival. It's really poor. It's really poor. And based on the data that you have right now, what would you choose or what would you recommend at the bedside? What factors would you take in consideration when you give a treatment recommendation for the patient, the first line or the second line?
Yes,
treatment?
the first is a maximal aggressive surgical removal of the tumor with wide free tissue, and the second we have only 3 accepted chemotherapy regimen to treat. In Hungary we use 1, the fluorouracil cisplatin, but no immune checkpoint inhibitor is available as a first-line treatment, and we use this therapy. We have 11 patients who received this therapy now, but we to every patient, we have to write an individual approval to the government, but they always give us the approval. But I think it's not enough. The immune checkpoint inhibitor therapy not enough alone. So in our second topic, we investigate the combinations therapy too. We will do a subgroup analysis, because in our first topic, we see immune checkpoint inhibitor therapy with combination in chemotherapy, the 2 article with better survivors has a much higher survival rates. So if I can, I advise the patients immune checkpoint inhibitor with chemotherapy.
I would really want to emphasize what's been said, because the first project is really tricky, and you have to be really very careful what conclusions you draw out of that. And it's really nice how you kind of identified these problems and then develop this project with the second step and with the third step. So that is very, very concise, and that's what research is about, that you find the limitations and acknowledge the limitations of a project, and then really try to how you can develop and improve that. So that's fantastic. From the first project where you compared chemo to IO, did you explore, did you have the data on any predictive biomarkers like PD-L1 or TMB? Was the information available on that?
There's a few immune checkpoint inhibitor articles where the PDL expression is available. It's very, very few articles. For example, no, it's HPC. This is the PDL1 subgroup analysis. And there's a very, just 3 articles involved with 38 patients. So we can make a hard conclusion from this.
Mm-hmm. So very moderate effect of the predictive biomarker, right? Yes. And then I apologize, but the first and the second project opens up this whole methodology and statistical issue of case control studies and all sorts of biases. So, and obviously you have thought about that when planning this retrospective study where you want to compare IO to chemo. What have you identified as the most relevant parameters and factors that you have to ask and to address to kind of minimize the confounders in this project?
Yes, thank you. In the articles, the outcomes publicated in a very heterogeneous way. But in every article we choose, there's contains Kaplan-Meier survivor plots with risk of patients of risk table and with censoring. Or some articles have the detailed, only 2 articles, the detailed patients' needs, how old was the patients, what kind of therapy get, the survivor times. So we choose extracting the data from Kaplan-Meier plots, and we make a survival analysis. So it's a good estimation of individual patients data to pull to extract the data from Kaplan-Meier if you know the number of risk and the censoring.
And when you want to push it further and develop it further and go into, for example, a randomized controlled trial, then you would kind of want to identify the 2 or 3 most important factors, and you would use them as stratification factors that influence the treatment. So having the experience in this field, what would be kind of the 3 most important factors that you would choose as a stratification factor for your clinical trial? Is it patient's age or number of lines of chemo, for example, or what would be?
Yes, I think in penile cancer, it's really a very real disease. In the last 7 years, we just only have 14 patients who need systemic therapy. So in this rare disease, we need every detail to make some suggestion for further research or therapy. I think age is not important. These patients usually have ECOG 0 or 1 performance status, so usually they are healthy, haven't got hypertony or diabetes, just the penile cancer. Maybe the previous malignancy or treatment, the exposures with chemicals or smoking habits and sexual behavior, and the social background is very important, because if somebody have a lower hygienic condition, it's a very high risk factor to have penile cancer.
And do you know whether the time between the last treatment stopped and the time of recurrence, is that important? So is it important whether the time between last treatment and recurrence is after 3 months or 6 months or 12 months? Does it influence the response rates to IO or to chemotherapy?
I think it would be important, but from the daily practice, I see that if somebody fall in chemotherapy, we have no long time. So after the disease is recurrent, we have to give. So if we, in other way, if we can't treat the patients in the first time, we won't have disease-free time after that, so we have to give them a sudden salvage treatment.
And does the type of treatment differ? So if a patient recurs after 2 months, do they get the same treatment type of drugs as patients that recur after 12 or 14 or 24 months? Is the chemo regime a different one, or do they get all the same treatment? So irrespective if they have the recurrence within 2 months or 12 months?
Usually we check first at 3 months, end of the 3 months, and if there's a high progression, we have to change our therapy. But if just a little progression, we have to wait, especially in immune checkpoint inhibitor therapy, because in the beginning of the therapy, the immune cells infiltrate the tumor and it looks like higher with CT examination.
Yes, I have 2 questions. One is not your official stats question. I'm just curious how you got down to 5, because you had quite many eligible full texts. So how did you exclude all of the others?
Yes, that 58 articles, 25 was in chemotherapy, and the last is immune checkpoint inhibitor therapy. So we got 2 arms, and we have to select, so we collected the case serials, case reports, conference abstracts, and we have to exclude the overlapping population and the articles which not give us enough information.
Yeah, thanks. The stats question is just, what's median survival time? What does it mean?
Median survival time. Yes, median survival time is the time when half of the patients, 50% of the patients, are still alive.